Hi and welcome to this video on NIPT in 30 minutes. And in this 30 minutes, I'm going to tell you everything you need to know about NIPT and what is relevant to your clinical practice without going into unnecessary theory. And I promise you, if you stick to the end, it will completely change the way that you have been thinking about NIPT all this while, and I think you will really be able to help your patients better. So without wasting time, let's go to the content. But first, we need to learn a little bit of statistics, and this is most important because if you have to understand NIPT, you have to understand how those things work and how you can apply them in your practice. And for that, I'm going to start with an example which has got nothing to do with NIPT or nothing to do with obstetrics at all. Okay, so we are going to start with 1000 patients who came to a hospital yesterday with chest pain. So obviously when a patient comes with chest pain, 1000 ECGs were done, one in each of those patients, and 100 of them out of those 1000 actually had a heart attack or a myocardial infarction, but ECG picked out 99 out of those 100. Now when a test picks out 99 out of 100 cases, we say that this test has a sensitivity of 99%. The second part is where most people go wrong. Every test has something called as a false positive rate, wherein the test will say that something is wrong, but actually nothing is wrong. Okay, so let us say that ECG has a false positive rate of 1%. Now I want you to think, does this 1% apply to those 1000 patients, the entire population who came with chest pain, or does it apply to those 100 cases of heart attack which were actually there in that population? Now most people think that 1% false positive rate applies to the cases which are diagnosed. That is absolutely wrong. False positive rate is always calculated as a proportion of the entire population which is tested. So here in this case, when we talk about 1% false positive rate of ECG, it is 1% of 1000. That is 10 cases out of those 1000 will get a false alarm on ECG. So ECG will show that they are having a heart attack, while in reality they will be absolutely fine. And the entire concept of NIPT is based on this false positive rate. Okay, so again, false positive rate applies to the population being tested. It does not apply to the number of cases that have been detected, and I want you to remember this throughout the presentation. Fine. Now my first statement is this: NIPT measures fetal DNA in maternal blood. We all know this, or we all think we know this. So I am going to add a bit of a confusing question here. So I want all of you to answer to yourself, true or false. Does NIPT really measure DNA in maternal blood? And we'll go through it. Okay, so when you look at maternal blood, DNA exists in two forms. One is it can be in the cells. We'll have WBCs in DNA with them, and all cells which are floating in the maternal blood will have DNA. It's called as intracellular DNA. Okay. Now, also some of these cells break down and the DNA from these cells is released into maternal blood, which is freely floating in maternal blood. And this DNA bits which are freely floating in maternal blood, which are not inside cells, they are called as cell-free DNA, and this is what NIPT basically measures. The question is, does fetal DNA enter maternal blood? Okay, now just look at the placenta. Now let us say we talk about giving thyroxine to the mother. The thyroid hormone is such a small tiny molecule. Does it cross the placenta? No, it does not cross the placenta. So the placenta, which does not allow even a tiny molecule like a thyroxine molecule to cross itself, will it allow fetal DNA to cross itself into maternal blood? No. So the placenta does not allow fetal DNA to cross into maternal blood. Now very rarely, sometimes there might be a small breach here and there by which one molecule or one bit of fetal DNA may rarely enter the maternal blood, but immediately what happens is that a maternal macrophage will come and eat it up completely. So what do we conclude? That fetal DNA is not found in maternal blood. Surprise. Okay, so that means NIPT does not measure fetal DNA in maternal blood. So the answer to this question is false, and this is why NIPT is not considered as a diagnostic test, simply because fetal DNA is never found in measurable quantities in maternal blood. So then what does NIPT measure? Cell-free DNA in maternal blood comes from two sources, the mother and the placenta, not the fetus. Okay, 90% of cell-free DNA comes from the mother cells itself. So from all parts of the mother's body, from the brain, the heart, the muscles, the eyes, the blood vessels themselves, all other tissues, stomach, everywhere the cells are being shed, and these cells in maternal blood will break down and release their cell-free DNA. So 90% of cell-free DNA in maternal plasma comes from the mother itself. 10% comes from the placenta. And how does it come from the placenta? Now if you see the maternal side of the placenta is in constant touch with the mother's blood. There is interaction between the placental surface and mother's blood for exchange of various nutrients and other substances. So in this outer layer of the placenta, there are cells, that is syncytiotrophoblasts and cytotrophoblasts, which are dying, and as they die they release DNA bits which enter the maternal blood. So 10% of the DNA in maternal blood, that is the cell-free DNA in maternal blood, comes from the placenta. Now most NIPT tests use something called as massively parallel sequencing or next generation sequencing to try and reach a diagnosis. Okay, so how is it done? The first step is a rough estimation of the fetal fraction. And again, remember, when I am saying fetal, actually it is not the fetal, it is the placental fraction. Okay, so for that they use, either if it's a male fetus, you can use certain probes which detect the presence of amount or proportion of the Y chromosome DNA, because obviously it is not there in the mother. Also they have found that the placental DNA and the maternal DNA has some methylation differences. Okay, that is the amount of methyl groups which are present in that DNA, and based on that a rough estimation can be made as to what percentage of the cell-free DNA is maternal in origin and which part is placental in origin. But very importantly, as I said in the beginning, the analyzer does not know which of those bits is actually maternal and which of those bits is placental or fetal, because all DNA looks the same. So what it does is, in first step, it just amplifies all the cell-free DNA. So there was a bit of DNA which we sent as a sample, it is amplified so that you get lot of DNA which is basically multiple copies of the bits of DNA which are there in the original sample. After amplification, this entire bit of DNA is sequenced and it is grouped according to which chromosomes it is coming from. Okay, remember, even at this stage we have no idea which bit comes from the mother and which bit comes from the placenta. Okay, based on the amount of DNA which is located on each chromosome, the sequencer or the analyzer then plots a graph. Okay, so let us assume that the baby has got trisomy 21. Okay, now as I said, this blue bit resembles the maternal DNA, so you will have 90% of DNA coming from the mother, which will be the same. Then this green bit is the normal placental DNA which is expected to be there, and this small red bit which is over and above the others is the extra DNA which is coming there because there is one chromosome which is extra. Okay, so you will have a slight amount of increasing DNA corresponding to chromosome number 21, and based on this we can conclude that there may be presence of trisomy 21 in the fetus. Now these colors are what I have used to show you the origin of the DNA, but how does the analyzer actually see the DNA? Like this. For the analyzer, everything, the maternal DNA, the placental DNA and the extra bit of DNA all look the same color. So the analyzer software cannot distinguish which comes from the mother, which comes from the placenta, and which is that extra bit of DNA which is there. But when it notes, and this point is very important, when it notes that there is a slight bit of DNA increase corresponding to chromosome number 21, it concludes that the fetus is having trisomy 21. Why? Because the mother is obviously not Down syndrome, so the extra bit of chromosome 21 DNA which is coming there in the sample must be from the baby. So therefore we say that NIPT is not a diagnostic test, it is simply a statistical test. So that's why non-invasive prenatal testing is now more correctly called as non-invasive prenatal screening, because it is a highly sensitive screening test. Now, though I have said that it is a statistical test, it is very good test for common trisomies, okay? And for trisomy 21, trisomy 13 and trisomy 18, detection rates are 99%, which is highly accurate. So NIPT is very good when you have a screen positive double or quadruple marker, because it helps to avoid amniocentesis in this patient. Also, it can be used as a first line screening test instead of the double marker test or the quadruple marker test, but at present it is relatively expensive, and I think maybe over the next 10 years NIPT is going to be the first line screening test for common trisomies. Now, because of its inability to differentiate the source of DNA, NIPT is less accurate in dichorionic twins. Why? Because you have two babies, so every baby's placenta is sending its own DNA, so it is difficult for the NIPT to know which of the baby is affected, because they will be releasing different amounts of DNA corresponding to each chromosome. Okay, so you have more than one source of DNA, you have two placenta, so there is a problem. Vanishing twin, it's a big problem. Now what happens is, in vanishing twin you have a live baby and you have a baby who has died, but that baby's placenta is still present, and that baby's placenta, the baby who has died, that placenta is degenerating at a faster rate, so that releases more DNA in the maternal blood compared to the healthy twin. So because NIPT cannot distinguish where that DNA comes from, it is, and the baby who has vanished is more likely to be abnormal, you can get less accurate results. Again, in donor egg IVF it is less accurate, because now you have three different origin. Originally, when you see cell-free DNA, you have the maternal part of the cell-free DNA and the fetal or the placental part, which half of it resembles the father, half of it resembles the mother. But now here you are having a donor, which is the third source of completely different DNA. So this can sort of confuse the analyzer and you can get slightly less accurate results. And of course, confined placental mosaicism is a very rare condition in which the placental genetic constitution is different from the fetal, in which case your NIPT will reflect the placental condition and not the fetal condition. Now, what about false positive rates? If you see the specificity of NIPT, it is even higher, it is 99.95%, and false positive rates are only 0.05%, so very low. So if NIPT is so accurate that it is 99% sensitive and 99.95% specific, do you need an amniocentesis after getting a positive report of NIPT? Or can you, if NIPT shows trisomy 21, can you go ahead and terminate the pregnancy? Okay, for this let us go back to the heart attack slide of the beginning. Okay, now remember I had told you that the false positive rate of 1% applies to the entire population. So in that case it was 1% of 1000 or 10 cases. Okay, now this same principle we will apply for NIPT and see how it works out. Let us take 1 lakh pregnant woman, all of whom are aged 30 years, theoretical example. So if you look at Down syndrome, the age risk or the chances of number of people who will have Down syndrome out of this 1 lakh people will be about 1 in 1000 because they are 30 years old, or 1 in 1000 of 1 lakh is 100. So in 1 lakh pregnant woman there will be 100 babies with actual Down syndrome. Okay, now forget about the sensitivity, I'm not going to talk about it. Now let us see what happens to the false positive rate. Now as I said, the false positive rate refers to the percentage of the entire tested population who gets a false positive result. So in this case, it is false positive rate is just 0.05, but 0.05 of 1 lakh is 50. So 50 patients are going to get false positive NIPT report, which means that if you have a 30-year-old population and if you get 150 NIPT positive reports for Down syndrome, out of those 150, only 2/3, that is 100, will actually have Down syndrome, and 50 out of these 100 will be false positive NIPTs. Okay, so and at the age of 30, 1/3 of all NIPT positive results will be wrong. Okay, which is why you should never terminate a pregnancy based on a NIPT report. And I'm going to repeat again, never ever ever terminate a pregnancy based on NIPT report. It can be wrong. You need to confirm with amniocentesis. Okay, now let us look at some other topics. Nowadays many labs are offering something called as expanded NIPT. They are saying if you can look at trisomy 21, why not look at all chromosomes, or why not look at all genes, or why not look at microdeletions and so on and so forth. And there are very good offers which, you know, for the same price a patient can get a lot more information. The question is, should you be doing an expanded NIPT? So for that, let us take an example of a rare syndrome called as a Prader-Willi syndrome, which can be detected on an NIPT. Okay, it's a microdeletion syndrome and you don't need to know anything about it. It's a very rare syndrome, but basically I'm just using it as an example. A small portion of paternal chromosome 15 is deleted. Okay, incidence is 1 in 20,000. It causes a lot of abnormalities like mental, developmental and physical abnormalities. We'll not go into that in detail, but it's a very rare condition, and NIPT has got a high sensitivity rate, that is 99% sensitivity, and a low false positive rate of 0.1%. So should you be using NIPT to detect Prader-Willi syndrome? On the face of it, it looks like a very good test. Let us go a bit into the detail. Now, this slide I had shown you for a Down syndrome fetus. Now, when an entire chromosome is extra, look at how little bit the DNA increases. For a whole chromosome, you will find that the net DNA increase which is detected by NIPT is very little. Now imagine a bit of chromosome 15 is missing, a small piece of chromosome 15 is missing. Do you think NIPT will be really able to detect the net change in DNA which is occurring in the cell-free DNA in the blood? It's very difficult. Chances of making an error are very high. Okay. Again, let's go back to our heart attack slide, and we are going to again look at what happens in Prader-Willi syndrome, which is a rare syndrome. So the rarer the syndrome, you will have more number of NIPT test results which are wrong, and this is why. Okay, so again let's go back to that. You have 1 lakh pregnant woman aged 30 years. Now Prader-Willi syndrome risk is 1 in 20,000. So in 1 lakh woman you will just have 5 cases where the baby actually has this Prader-Willi syndrome. Okay, now false positive rate refers to the entire tested population, and Prader-Willi syndrome is a 0.1% false positive rate, which means you will have 100 false positives for Prader-Willi syndrome. So when you do NIPT for Prader-Willi syndrome, if you get 105 NIPT positive results, out of those 105, only 5 will be actually affected and 100 NIPTs will be wrong. So the baby will be completely normal. Okay. So NIPT for these rare conditions is absolutely not accurate. The predictive value of NIPT is very, very low. Same way for others, like you have Dye-George syndrome where NIPT will be 81% wrong, you have Cre-Du-Chat syndrome where NIPT will be 80% wrong, you have Wolff-Hirschhorn syndrome where it will be 86% wrong. Okay. Now, testing other chromosomes. If you are testing for trisomy 21, why not test for trisomy 1, 2, 3, 4, 5, 1 to 22? You can test for everything. Should you be doing it? Absolutely not. First, other trisomies are extremely rare. Okay. So again, you will have, I don't want to go through that slide again you will have lots of false positives. NIPT for rare autosomal trisomies are not validated in large scale studies. And third, and the biggest problem is, if you get a result something like trisomy 1. Now tell me one thing, have you ever heard of any human being with trisomy 1 or any fetus with trisomy 1? No, because if you actually have trisomy 1, a human being cannot be formed. So if there is fertilization and if there is trisomy 1, it will be a blighted ovum. You will not have a fetus. Now you have already done an NT scan and you have a live moving jumping baby with a head, with eyes, with hands, fingers and everything. You know that this cannot be a trisomy 1 baby, because a baby cannot form with trisomy 1, but then your NIPT is showing trisomy 1. So how do you counsel the patient? Are you going to do an amniocentesis? Because you know that it cannot be, you know that the NIPT report is wrong. So you can get all sorts of weird results. Now, fetus with an anomaly. Okay. Now, if you have a fetus with an anomaly which is strongly suggestive of a chromosomal disorder, like say you have duodenal atresia, okay, should you do an NIPT? Absolutely not. Why? Because risk of aneuploidy, say in duodenal atresia, there is a 30% risk of Down syndrome. So it's very high. And NIPT is just a screening test. It's not a diagnostic test. Also, some of the anomalies like cardiac anomalies may be associated with some micro deletions like 22q11, which will not be detected correctly on NIPT. So if there is a fetus with a abnormality, please, if you do want to do any sort of genetic testing, go for invasive testing like either a CVS if it is detected early, or an amniocentesis if it is detected in the second trimester. When you have a previous baby with Down syndrome, it can be of 3 types. So that is why the first and the most important thing that you do when you have an index child with Down syndrome is to karyotype the index child. Okay. Now, the most common condition which can cause Down syndrome in a child is something called as pure trisomy 21, when there are 21 chromosomes. Okay. In such cases, the recurrence risk in the next pregnancy is very less. It is just about 1%, and in the next pregnancy, therefore, it is fair enough to do either maternal serum screening or NIPT, or if the patient really wants, you can go for amniocentesis. So normally patient should be given a choice, but in these cases, since the recurrence risk is low, NIPT seems to be a fair test to do, so that it is much more accurate than maternal serum screening, but it does not have the risk of amniocentesis. The second type of Down syndrome which can exist is something called as mosaic Down syndrome. In these children, half the cells or a certain percentage of cells are completely normal and other cells are showing trisomy 21. Now this is formed by something called as a trisomic rescue, which occurs after fertilization has occurred, and again its recurrence risk is same, it is 1%. Basically it happens by mistake, it is not inherited per se. So the chance of the next pregnancy next fetus getting this is about 1%. So again in the next pregnancy, it's fair enough to do either maternal serum screening, NIPT or amniocentesis. Again, we do NIPT in most of these patients because it seems like a fair deal between serum screening and amniocentesis. The third and the last type is something called as translocation Downs. Now this is very important. Here what happens is a bit of chromosome 21 gets attached to another chromosome like chromosome 14 and comes piggyback riding as an extra chromosome. In this case, it might be de novo, that is happening by chance or first time in the fetus, or it might be present in the parents as well. Recurrence risk can in translocation downs can be as high as 25%, and if you have an index child with translocation downs, you should always go for amniocentesis or CVS in the subsequent pregnancies. NIPT or serum screening is not to be done. Now, which are the maternal conditions which can affect NIPT results? First, if mother is a Turner syndrome mosaic. Now, if you have pure Turner syndrome, the mother will be infertile. So, the woman will be infertile. She cannot have children. But there are mosaic individuals with just 10% of cells having Turner syndrome and 90% of cells being normal. Now, when you do NIPT, in such cases, the mother becomes pregnant and you do NIPT, there will be an effect of her own cell-free DNA, and the fetus might be reported as NIPT high risk for Turner syndrome. So you should be, if a fetus shows NIPT report as high risk for Turner syndrome, you should always confirm by amniocentesis, and if it is normal, you can consider testing the mother for Turner syndrome. The second is if mother has a malignancy. Now with malignancy, what happens is lot of cells are anaplastic, so they are dividing in abnormal ways, so you will have all sorts of chromosomes being formed and destroyed. Okay, so these will result in a lot of abnormal DNA being released in the mother's circulation, and if you do NIPT during her pregnancy, you might get a report which shows multiple trisomies. Okay, so now if you do an NIPT in a woman and it shows fetus is positive for trisomy 21, trisomy 13 and trisomy 18, seriously, the fetus can't be positive. What are the chances of being positive for 3 trisomies? In such cases, when you get such weird reports, you should look at the mother and you should suspect the possibility of some malignancy. Now, just before I conclude, there are certain NIPT techniques called as single nucleotide polymorphism based NIPTs. What they do is that they try to find out differences in the DNA between individuals. Okay, so what they are going to do is that though many individuals have similar DNA on each chromosome, say chromosome 21 DNA in me and in you will be almost the same, but still 1 or 2 bases here and there are different, and this SNP based NIPT finds out the difference in bases to basically try and label which DNA bit comes from whom. So it can be used even in conditions like triploidy, it can be used in twins, it can be used in vanishing twins, and even theoretically in maternal mosaicism you should not have a problem because fetal DNA is tested separately from the maternal DNA, it is isolated. But though in theory this is a very good test, still it is not considered a confirmatory test because there are fewer studies on SNP based NIPT. Again, if you do it in twins, it can tell you that one twin is affected, but it will not tell you which twin is affected. So if one twin shows trisomy 21 on NIPT, you need to sample both the twins because it doesn't tell you from ultrasound point of view which is the affected twin. And again, I think no lab commercially, as far as I know, offers SNP right now in India. So it's not available option for us in India right now. Anti-scan in the area of NIPT. So if NIPT can detect so many things, should you be doing anti at all? Absolutely. Purpose of anti-scan is far bigger, to detect size, to detect gestation, to detect number of fetuses, and we are now looking at a lot of anomalies in the first trimester. So never ever do an NIPT without having done a anti-scan, and if anti-scan shows a gross abnormality, you should be doing an invasive testing. Okay. Now NIPT is a screening test for most conditions, but it can be a diagnostic test in 2 conditions. One of them is fetal RH status for isoimmunized pregnancies, and second is fetal gender when you are looking into cases like hemophilia and all, which are X-linked basically. However, obviously detection of fetal gender is banned in India, so we are going to just look at fetal RH status, and I will show you why it is diagnostic and it is not just a screening test. And again we are going back to our heart attack wala slide, and again you have say 1 lakh pregnant woman, incidence of RH positivity in their fetus is is about 90%. 90% of people in the world are Rh positive. So in 1000 pregnancies, you are going to have 90,000 Rh positive babies. Okay. Again, false positive rate is about 0.05%. So you are going to have about 50 cases who are false positive. So if you have 90,050 NIPT reports for a Rh positive status of the baby, 90,000 of them are actually going to be right and only 50 are going to be wrong. Okay, so for Rh positive status, NIPT is 99.9% accurate, unlike for Down syndrome screening. So it can be used as a diagnostic test and it is not a screening test. So to conclude, NIPT is very useful in these cases. First, after maternal serum screening, that is if you have a combined first trimester screening which is positive, if you have a quadruple marker which shows a high risk, or if you have a intermediate risk. So in this group of patients you can actually avoid amniocentesis. Also, it can be used as a primary screening instead of doing double marker and quadruple marker. In which cases, one, if the patient wishes to do so, it costs a bit of money, but if the patient wishes, you should offer her that. Advanced age, patient is 44, 45 years old, 43, 44, 45 years old and has conceived spontaneously, not through donor IVF because donors are young, but if patient conceives spontaneously at 44 or 45, incidence of Down syndrome is very high in her compared to the general population, and you can directly offer NIPT instead of a combined screening or a quadruple test. And previous child with trisomy 21, which I have already explained. And again, diagnostic use, Rh status, it is available in India now and we are starting to use it. It's recently available since last few months. And fetal sex, of course it's not allowed in India, but in countries where it is allowed, it can definitely be used to so let you know whether it's a male or a female baby in cases of X-linked disorders. And where is it less accurate? I have already explained all of this. Let me just quickly go through the list. In dichorionic twins, in vanishing twin, in donor egg IVF, in anomalous baby, in microdeletions, while testing for other chromosomes other than 13, 18 and 21, in single gene disorders, and in translocation Down, you should not be doing an NIPT or double marker test in the next pregnancy. You should be directly going for an amniocentesis. So I hope that you have learned what you needed to about NIPT in a very short time, and I have tried to present only those concepts which are clinically important to you, and I hope that this really helps all of you to give better care to your patient and also prevents terminations without confirmation when you get a NIPT positive test. Thank you so much. I enjoyed making this video. I hope you like it too.